And first of all, I'd like to thank Professor Sheena and the team for this invitation. It's always great to come and present our work to a non-psychiatric audience, and especially to neurologists. I have a personal bias because my wife is a neurologist, but at the same time, I think the two fields are so closely linked that I think it's amazing to see how much I can learn attending these kind of conferences. So this is my acknowledgement, a conflict of interest. I'm funded mainly by the National Institute for Health Research in the UK, and I'm a clinical academic, so I see patients once a week in the clinic, and the other days are for research. And the main, I think, conflict of interest for today is I need to apologize with you, because this is probably the most boring lecture of the whole conference, because it will be a lot of data, a lot of presentation. I'll do my best to make it focused on clinical implications, but there's a bit of basic statistics that we need to go through. So please forgive me. And I know it's a lecture, but if there's anything you don't really get when I'm presenting, do not hesitate, raise your hand. I'll be happy to explain again if needed, because it's crucial that we go step by step. It's a very complicated topic, an area of evidence synthesis. I'll come back to this in a sec. But I'll try to make it as simple as possible, okay? So just to get the key concepts around network meta-analysis and why they are so important, I think, especially for a field like migraine. And I see a lot of overlaps with mood disorders, especially depression. So first of all, this is the outline. What is a network meta-analysis? What are the two key assumptions which are crucial if we want to do a network, meta-analysis? I'd like to present the example of antidepressants for depression, because after last night dinner, I think it would be good to give you a real example of something similar to what we heard this morning about the acute and preventive treatment for migraine. Two aspects about the I'm not touching, sorry, but two aspects about the geometry and the graphical representation of the results, and then how the network meta-analysis data can be used to personalize treatment. So this is what we usually teach to our students. Apologies, I tend to move a lot. I'm Italian, so I tend to touch people. I tend to move around, so please forgive me. But, I mean, I can see in your eyes, so it's nice to be a bit interactive. So this is what we teach to medical students and DPhil students, the hierarchy of evidence based on what we know about the data. And the reason why this is possibly a good example is because, this is one from the Center for Evidence-Based Medicine in Oxford, is because the first thing is on this gray column, it depends really on the clinical question. Because if the question is about therapy, or what we discussed earlier this morning about the effects of medication or tolerability of drugs or interventions or acceptability, of course, it's one thing, but if we move to prognosis or diagnosis, these are different questions, and these are answered by different study designs, hence different hierarchy. So for the sake of this presentation, let's focus only on the first, so about treatment or therapy. And the levels of evidence are divided into 1, 2, 3, depending on the study design. So level 1 is randomized controlled trial, because an RCT, using an RCT design, you rule out what we call the selection bias. So you don't choose patients based on characteristics. They are randomly, so by chance, allocated to treatment A or B. So at the end of the study, if you find an outcome or significant association, you can reliably say this is due to the specific intervention, because all the other characteristics are similar between the two groups. And 1A or 1B is tiny difference, and the difference is numbers, size, population. So level A means a systematic review, so a collection of studies about the same topic. 1B is one individual study. The reasons are twofold. One is the more the merrier. If you have more people, you can have more power when you do the statistical analysis. But the second is if you have a large population, you increase what we call in technical terms external validity. So you are collecting data about diverse or different populations, so you can apply the results of the meta-analysis to the real world, or you're closer to the real world population. And then level 2 is cohort studies, and level 3 is case control, so prospective, retrospective studies. So are you happy with this? Yes, great. I'm not. I'm not for one specific reason, because as a clinician, I don't think that all that I showed you really help what we are trying to do. And let me give you an example. It's a real example, of course, outside psychiatry, because I want to keep my job. But it's a great example, because in this case, the problem is not the quality of the systematic review. It's not the work that the author did. They are great authors, great researchers, great journal, interesting topic, if you want to say. So it's safety and effectiveness of different methods of earwax removal. So it can be anything. So I'd like to show you why this great piece of science doesn't really help us when we need to take decisions in the clinic. And let me skip to the abstract and the results section of the abstract. So this is somehow the take-home message from this paper. And look at this. On measures of wax clearance, Ceramol, sodium bicarbonate, olive oil, and water are all more effective than no treatment. This is the first finding. Second, TP is better than olive oil. Third, wet irrigation is better than dry irrigation. Fourth, sodium bicarbonate drops followed by irrigation by nurse is more effective than sodium bicarbonate drops followed by self-irrigation. So that's the problem. Can I ask you, what is the problem? At least the problem I see. Any clinician in the room? It is quite messy. Exactly. It is messy, and what is missing is how do these treatment options rank one against the other? Second, how big are the differences? Before we had a patient representative, every time I'm in the clinic and my patients ask me, what is the difference between two treatments? How big are the differences? Because we need to inform the clinical decision-making process. We should move away from the paternalistic approach. Believe me, this is the best treatment. Go away and take it. That's old age psychiatry, at least. So this is the limitation of the methodology, because if we are really interested in comparing multiple options, the standard or pairwise meta-analysis doesn't really help. Because this is an example of a standard meta-analysis, which is a great piece of science because you lump together different studies. So you have 3 studies comparing A versus placebo, and at the end you have a pooled weighted estimate. Rather than having 3 different estimates for each study, you have 1 estimate for everything. But if I want to compare B versus placebo, I have another 4 studies, another pooled estimate. And these are telling me what is the difference A versus placebo, B versus placebo. But if my question is, what is the difference between A and B? And there are no studies, exactly what we were discussing this morning, where Dr. Doe mentioned. If we don't have comparative data between A and B, what's the answer to my patients? So we have a framework, a methodological robust framework to answer this question. And in a nutshell is this. So if I have, as I said, a group of, so this is slightly different, but if I have a group of studies comparing A versus placebo, and another group of studies comparing A versus B, and I have A as a treatment in common, I can calculate the indirect evidence, B versus placebo, and fill the gap. Let me show you a real example. This is a paper we published in The Lancet in 2009. It was the first network meta-analysis ever done in psychiatry. And I was completing my training at that time. And one of the big questions I had, I kept asking my senior colleagues was, I have a patient with depression. We agreed to prescribe an antidepressant. I know we need to follow NICE guidelines, which means we need to prescribe a second-generation antidepressant. But which one, if any, is the best treatment for the patient? Are they all created equal, or are there differences between antidepressants? So this is why what we did in 2009 was comparative efficacy and acceptability, dropout rate, of 12 new generation antidepressants. And as you can see, this was table 1 of the paper. Traditional standard pairwise meta-analysis, they don't help really, because for bupropion, you can see out of 12 possible comparisons, we only had 5, and so on. And I remember discussing with the Lancet editor at that time, they didn't want this table in the paper, but I really wanted the table to show, to reinforce the message that network meta-analysis is really a step forward in terms of knowledge. And this is the network. This is why we call network meta-analysis. This is the graphical representation, and we have 12 nodes, and each node is one drug. We're talking here about antidepressants, and the size of the node is proportional to the number of patients randomized to each intervention, each drug. So you can see here, we have a lot of patients randomized to fluoxetine, not so many to duloxetine, and so on. The lines represent the trials comparing the two drugs, and the width of the line is proportional to the number of trials comparing the two drugs. So we have a lot of studies comparing fluoxetine with venlafaxine, not so many fluoxetine bupropion. Look here. We don't have studies reboxetine, mirtazapine. So if the question is what's the difference between the two drugs, standard meta-analysis say no, I don't know. With a network meta-analysis like this, I can use the common comparator, for instance, fluoxetine, which is the solid red line, to calculate the indirect comparison mirtazapine, reboxetine, the dotted red line. So with network meta-analysis, I fill the gaps in the network. But there's another great advantage of network meta-analysis, I think even more important, and I'll explain why in a second, which is using the full potential of the network. I just said that we have a lot of studies comparing sertraline with fluoxetine. You can see it's a very thick line. But I can use, and now the solid red line, but I can use the network to also calculate the indirect evidence sertraline fluoxetine using a common comparator. So I have solid yellow line, I have sertraline venlafaxine, I have fluoxetine venlafaxine, so I can also calculate which is the indirect evidence sertraline fluoxetine via venlafaxine. And this is why we call network meta-analysis also mixed treatment meta-analysis, because I can compare direct data versus indirect, because my expectation is that the direct data, so the solid red line, matches with the dotted yellow line if the network is consistent or coherent. And this is a terminology that I'll explain in a second. It's called consistency of the network. The other thing is, I don't go only via venlafaxine, but in the network meta-analysis, I use all information across the network. So I can calculate the dotted yellow line also via other triangles, via citalopram, for instance, or via mirtazapine, and so on. I can also have 4-node loops. For instance, here, fluoxetine, S-citalopram, paroxetine, sertraline. The higher the number of nodes, the more uncertain is the estimate, so the wider are the confidence interval. But I take everything into account. I'm not hiding anything. I use all the data available across the network. And I can produce a league table. So I showed you table 1, and this is the league table where we have all the drugs in alphabetical order. And here on the bottom left, I have efficacy, response rate, 50% reduction. And on the top right, I have acceptability, dropout rate. But as you can see, all the cells are filled with an estimate. How I read this is the vertical, so the column defining versus the row defining. So look at here. I have mirtazapine versus reboxetine. And rather than having a blank cell, because I don't have direct data, I have an estimate calculated by the indirect data using the whole network, first. Second, highlighted in bold are statistically significant results. So not only I fill the gap, but I can find, as in this case, statistically significant differences between drugs, not compared directly. And I can do this for efficacy here, and the same for acceptability. In this case, mirtazapine is slightly better, but not statistically significant. The other great advantage of using the whole information across the network is I have more precise information because, as I said before, the more the merrier. So I have more people across the network, so I have narrow confidence intervals. And this is the case fluoxetine versus sertraline. If you look at fluoxetine, sertraline, the direct data, the solid red line, it favors sertraline, but the confidence interval is so wide that it is very imprecise. Combining solid and dotted line, direct and indirect evidence, you can see here that the confidence interval is reduced. It is statistically significant. So I can really get additional information from the network meta-analysis that can help the clinical decision-making process. So the advantages of network meta-analysis: comparing interventions which haven't been compared directly in any trial, so filling the gaps, comprehensive use of all available data, direct and indirect, across the network. I just showed you about the improved precision for each outcome. The last bit about network meta-analysis is the ranking. So now I can compare how the different options rank against each other. And this is done by the software automatically. It's something like this. I need a volunteer. Can I ask you to help me? Thank you for volunteering. So when we rank, MTM is because we also call them multiple treatment meta-analysis, but it's the same. Network meta-analysis, mixed treatment comparisons, multiple treatment meta-analysis are the same. So the software estimates for each treatment the probability to be the best. So using the data from the league table, we can produce these probabilities. And in this table, the probability to be the first, in this example, we have only 4 options for simplicity. Okay, so 4 treatment, A, B, C, D. And I tell you that the probability for A to be the first is 25%. For B is 50. For C is 25, for D is 0. So can I ask you, the winner is?
I would say B.
Fantastic. Everybody happy? B. Why?
Because I understand it as it has 50% probability of being the best.
Exactly, so the highest probability. Bear with me. Tell me the second, the third, and the fourth, please. So B is the winner. Second?
Second is
C?
C.
Then
it's equally possible.
So there's no third place?
No, there is third place, but we cannot tell which one it is.
Any help or any different ideas? It's correct what you said, but I just want to see whether there are any interpretation. Exactly. So what you are doing is correct. So you're looking at the actual probability for each drug to be in each position. And if you look at the 4th position, you can see that D has 75% probability. So you can say, okay, so the third is A. But what we do, what the software does, is not only to look at the actual probability, but also to look at the cumulative probability. And the cumulative probability is very important because it takes into account the uncertainty around the estimate. We always want precision, but that's not the reality. We need to deal with imprecision. And this is what the software does. So if we stop at the 3rd position, if you look at the cumulative probability, for A is 75% probability to be among the best 3, 100% for B, 100% for C, and only 25% for D. So even if you stop at the 3rd, and even if it's true that the actual probability is the same due to the imprecision of the estimate, actually you can see at this level that probably A, 75, is better than D, 25. Do you agree? No? No?
Why not? 1, 1, and 1. If we take all 4 together, summary, at the end of the day, yes.
Yeah, it means that you have 100% probability
Each one, A, B, C, D.
to be among the best 4, which is true. Yeah, yeah. Okay? So, no, that's correct. We can do this, which is probably something that helps clinicians and patients. So based on the league table and based on the probabilities, we can draw some graphs showing for each drug, which is the probability to be in each position. We had, as you remember, 12 drugs in the Lancet paper, so we have 12 positions. And you can, sorry, the red solid line is efficacy response, and the dotted blue line is dropout rate. And you can easily see, if you plot the probability to be the first, the second, the third, the fourth, and so on, for paroxetine, it's unlikely to be one of the best treatments. If you look at sertraline, both are very good. Citalopram, very good for acceptability, not really for efficacy. Escitalopram, very good. Look at venlafaxine. It's the opposite of citalopram. Very effective, not well tolerated, and so on. This drug, reboxetine, forget about. There's no way it can be one of the winners. Okay? So this is a way to use the data, RCT data, so highest quality, in a more informative way. So, again, apologies for the boring part, but it's crucial that you don't trust me. I need to prove that these are correct data. So there are 2 assumptions, and these assumptions are the cornerstone for any network meta-analysis, which means when we draft the protocol, we need to discuss about this assumption, but when we publish the paper, we need to address these, because otherwise the results are not valid. And one is transitivity, also called similarity. The second one is called inconsistency or coherence or congruence. So what is transitivity? Transitivity is, first of all, something that we cannot test statistically. It is something that we have to discuss and agree clinically, methodologically, from other point of view, but there's no statistical test to tell you this is transitivity assumption holds. And this is why my first recommendation, if you want to do a network meta-analysis, is to have a multidisciplinary team. You need to have clinicians, patient representative, experts in methodology, statisticians, and so on. And the key element of transitivity is, because we are comparing B and C via a common comparator, A in the trials AB and A in the trials AC have to be similar. How? Patient characteristics, intervention, anything. What matters from your point of view, but you have to be able to defend that these patients can be lumped together so you can go via A to compare B and C. If A in these trials is different from A in these trials, you can't do it. An example is placebo. If A is placebo, but in these studies, AB, the placebo is a pill, and in these studies, AC, placebo is injection, for instance, for depression, it doesn't hold. There's no way. The placebo response to an injection for people with depression is much higher than the placebo response in pill trials. Okay? So there's no point we can lump them together. But it may be that in headache this holds, or in other pain it holds, I don't know. So it's important that on a case-by-case discussion, a decision is taken, but we need to be aware of the problem about transitivity. Consistency is something we can test statistically. That's good news. And it basically says whether the direct evidence, solid line, and the indirect evidence, they match. And this can be done locally for each loop, as we call here, or globally across the whole network. But there's one thing you need to immediately notice here. that consistency can only be tested if we have direct trials. If we have a network without head-to-head comparisons, what we call a star-shaped network. So all the drugs are compared to placebo. Placebo is in the middle. All the drugs are linked to placebo, but there are no connections. You cannot test inconsistency because you need a closed loop to check consistency. Okay? This is another important thing to bear in mind. So very briefly to explain inconsistency or consistency compared to heterogeneity, which is a very important thing in standard or pairwise meta-analysis. So heterogeneity is a difference between studies. Inconsistency in a network meta-analysis is difference between sources of information, direct and indirect. So this is the heterogeneity. This is a standard forest plot. I'm sure you are familiar with the forest plot. So these 6 studies all together, there's no difference. You can see that the risk ratio is 1, absolute no difference. But if you look at the 6 studies, you can see that 2 studies here are on the right-hand side and 4 are completely different. I give you a tip. To see immediately that there's a huge inconsistency in this forest plot, look at the confidence intervals. Look at this confidence interval and this. They don't overlap. The assumption is, because we are measuring the effect across 6 trials and we are trying to find the true estimate within the confidence interval, if the true estimate for Arvola is between 153 and 594, and for Van der Hoef is between 0.29 and 1, which means there's no overlap, it's impossible, it's nonsense. And you can see here that the heterogeneity, the I-square, is 78%, which means that this result is explained almost by 80% by the heterogeneity. About 50%, we really question whether it makes sense to do a pooled estimate of the studies. Okay? So it may be that these 2 studies are kids and the other 4 are adults. So different population. We didn't expect any difference at the protocol development, but now we need to explore, investigate why we have these differences, and we may decide not to do a pooled estimate. So this is heterogeneity, differences between studies. Inconsistency is differences between sources of information. So if I tell you, can I ask you your help? Thank you. So if I tell you that A is better than B, and B is better than C, what do you expect? A is compared to C?
Then it's better, but
Exactly.
I cannot say how much.
Exactly. But because A is better than B, and B is better than C, you expect A better than C. Fantastic. If this is the case, the loop is consistent. But sometimes, makes sense, but sometimes you have that the real data, the direct comparison, tells you that A is worse than C. So it doesn't make any sense. So we say the loop is inconsistent. Less than 10% of the loops in a natural meta-analysis can be inconsistent by chance. If it's more than 10%, there's something wrong with the data. Okay? So this is why it's crucial when you read a natural meta-analysis to go in the results section and see whether the authors describe the inconsistency, because otherwise you don't have an element to judge whether the natural meta-analysis makes sense. And because natural meta-analyses are very popular now in the literature, don't waste your time, go straight to the results. If they don't explore transitivity and inconsistency, throw into the bin. There's no point. We have better things to do. So when we have the assumption, the first thing is, when we plan the natural meta-analysis, is let's see the network as a gigantic trial, where each patient can be, in theory, randomized to any of the nodes within the network. If this makes sense to you, then transitivity holds. Okay? This is what we defined the principle of jointly randomizable. of course, when we have the studies, we need to look at the potential effect modifiers, and this is why we do some subgroup analysis or sensitivity analysis to look at the distribution of these effect modifiers, which should be the same across the different nodes in the network. And third, of course, we need to test the inconsistency, as I said, locally and globally, and to see whether or not they are in agreement. This is a paper we published almost 10 years ago in the Annals of Internal Medicine. It's a good summary of what we should do when we address transitivity and inconsistency. Okay, the example of the antidepressants, which I hope can help the discussion about migraine. So this is an update, if you want, or expansion of the 2009 paper in The Lancet. Why? For a few reasons. First is, in 2009, what we did was to look at the active treatment. So we decided, can you be my patient for a moment? So we decided that an antidepressant is needed. So there's no point in asking whether antidepressants work, because clinically we decided that that's the way forward. Therefore, 2009 was, what is the best treatment for her? But in depression, there's a huge controversy about whether antidepressants really work. For this reason, the first thing is to ask, are antidepressants effective? And if so, which antidepressant? Are they the same or are they different? So in 2018, the question was a bit more elaborated. It was a two-step question, which means that for the first question about the theoretical efficacy, because we are not sure whether antidepressants work, therefore we need to compare antidepressants with placebo. Second step is, if we find antidepressants are efficacious, so better than placebo, what is, if any, the best treatment? We focused only on acute treatment because these are different studies. I know in migraine you have acute and preventive. That's fine, but these are two separate network meta-analyses, because these are two separate sets of studies, two different questions. Absolutely normal to have 2, 3, or 4 network meta-analyses in the same paper, but these are different individual projects with an overarching umbrella. So in this case, we focused on acute depression only. We decided to look at adults because we know that children and adolescents respond differently to antidepressants. So this is why the transitivity assumption is very important here. And we look at unipolar depression, excluding bipolar or psychotic depression, because again, the treatment is different. So here we are looking at monotherapy with antidepressant for non-treatment resistant people. And we wanted to compare, of course, all the licensed second-generation antidepressants across the world. We have also placebo, as I said, and because we wanted to do something global, we also included 4 reference old drugs. 2 of them are the 2 antidepressants in the WHO list of essential medicines. The other 2 are 2 antidepressants, nefazodone and trazodone, that are used especially in the UK, in the US, sorry, and in some countries in Europe because of very specific side effect profile. For instance, trazodone is very sedative. It's used a lot for people with depression. So this is why we have 4 reference first-generation antidepressants. When we do a network meta-analysis, all this has to be explained and detailed in the protocol, because then I can follow what is the pathway in terms of selection of intervention, which is a key element, because depending on the network, the results can be different. So this is the list of the 21 drugs in alphabetical order, the second-generation antidepressants, from agomelatine to vortioxetine, amitriptyline, clomipramine, the 2 WHO drugs, and as I said, trazodone and nefazodone. We exclude bipolar, psychotic, concomitant medical illnesses because of the comorbid treatment. The outcomes, the 2 outcomes we used in 2009, response rate and dropout rate, dichotomous outcome, because talking to patients, this is what they really are interested in. Talking to clinicians is the same. Do they respond to treatment? And can they tolerate the treatment after a couple of months. Secondary outcome, we look also at change in depressive symptoms, remission rate, and also, dropout rates due to adverse events. All these are acute treatments, so we use 8-week data, but we allowed a range between 4 and 16 weeks. So if the study lasted 12 weeks, we contacted the companies and so on to get the 8-week data. If we didn't get the 8-week data, we use anything closer to this time point. And because it's a clinical informative research project, we look at drugs within the therapeutic range. So we excluded below and above the drug range. So this is the Prisma flowchart, which is very important for any piece of evidence synthesis. The reason why I show you this is because if you look at this column, 25,000 hits or records identified using the standard search, the standard databases. And these 25,000 produced 421 randomized controlled trials. But if you look here, the search of the unpublished produced 86 additional studies not published on antidepressants in depression, and then checking the reference list or having conversations with experts in the area or people in industry, we found additional 15. So more than 100 studies, 20% plus, are completely missing in the published literature. And this is an important thing for the quality of the systematic review, but also for the data in the end. Okay, and the other thing I want to point out is we had 522 studies, about 120,000 participants, but we expected, having old second generation and new second generation, we have drugs like fluoxetine or paroxetine with more than 100 studies. The most recent drugs, vilazodone, desvenlafaxine, that have less than 10 studies. So this is also important to take into account in the overall picture. These are the networks. Can I ask you what you think? If you have to describe the two networks, so this one, the green one, is efficacy, so a response rate, and this is a different outcome, dropout rate.
I think they look quite similar.
Great.
And that's maybe not expected.
Well, we hope so.
Yeah.
We hope so, exactly. So, sorry, what's your name?
Lily?
Lily. So Lily, exactly. So what we call the shape or the geometry of the network is crucial. The two are very similar, which means that, exactly as Lily said, the outcome for efficacy and the outcome for acceptability, dropout rate, are based on the same patients. So the same studies contribute to both outcomes. So our initial hypothesis here, so these two outcomes are primary outcome, response and dropout, make sense because we have basically the same studies producing both outcomes. There's only two differences. For instance, if you look here, for acceptability, we have a study, bupropion, amitriptyline. Here we don't have. So this study is not reporting efficacy data. But apart from this study and another one, everything is identical, which is good. The other thing, Lily, that you notice in terms of geometry of the network?
I noticed that placebo is probably the one that's mostly connected to the rest of the...
Yes, that's another important thing. As expected, we know that we have a lot of placebo-controlled trials. Going back to the consistency, inconsistency, closed loop, how would you define the... How would you define the connections? Are there a lot head-to-head studies?
Not so many.
Oh,
I think.
Really?
Okay, you think they are?
Yeah, I think
because
yes.
For me, they stand out mostly towards placebo.
Yes.
They're so much stronger.
So, exactly. There are a lot of placebo-controlled studies, but as you can see, we have lines comparing head-to-head studies. which means, sorry, head-to-head comparisons, which means we can calculate the consistency for drugs versus another drug. I'll show you probably the ideal connection. The DL network is more connected, but believe me, compared to other network meta-analysis, this is a very well-connected network, which means I can test inconsistency. If I have a star-shaped network, there's no way I can test inconsistency. So this is a forest plot reporting the network meta-analysis data. Okay, so combine everything, but because the first question is, are antidepressants better than placebo, all the individual antidepressants are compared with placebo. So we have the antidepressants for efficacy, from the most effective to the least effective, and all are compared to placebo. As you can see, all the antidepressants are on the right-hand side of the forest plot. So they are all better than placebo. This is the first finding in terms of efficacy. The second is, if you look at the top, amitriptyline, and if you look at the one at the bottom, reboxetine, the confidence intervals do not overlap. So the highest for reboxetine is 163, the lowest for amitriptyline is 189. So because of what we said before, these are material differences between antidepressants. So it looks like antidepressants are different. They're all better than placebo in terms of efficacy, but they are different. In terms of acceptability, we have a couple of drugs better than placebo, one drug worse than placebo in terms of all-cause dropout. All the other are not statistically significant, so they are in gray. But if you look at the confidence intervals here for agomelatine and fluoxetine, they are very close to the line of no difference 1. So my interpretation is, in terms of acceptability, there are no material differences between placebo and antidepressants, which is somehow unexpected because you would say that being an active drug, they may cause more dropout, but that's not the case. So this is what we found, and this is a graph, a bidimensional graph, reporting exactly what we just said in the two forest plot. Efficacy and acceptability plotted against placebo. So you can see on the x-axis efficacy, on the y-axis acceptability. This is reboxetine, the least effective drug, and this is placebo. So this is just a visual representation of what we just said, that all antidepressants are better than placebo in terms of efficacy. In terms of acceptability, they are more or less the same. Okay? Happy? What happens if we exclude placebo? Because one of the big problems are placebo-controlled trials. So I expect that if the studies are similar, results will not change. But if you look at reboxetine, which will be the reference drug, so reboxetine is still the reference. This is what happens if we exclude placebo. So if we exclude placebo-controlled trials, the differences between drugs are much bigger. If we include placebo, they all shrink. And that's a bit of a headache, I would say, because how is it possible? So what we did was we analyzed the influence of placebo arms in trials. And this is the same sample of studies. So the impact of having placebo on efficacy and acceptability in studies about antidepressants, comparing the same drug, so the efficacy of the same drug, if tested in a placebo-controlled trial, compared to the same drug tested in a head-to-head trial, so without placebo. And this is what happens. So for antidepressants, the black is head-to-head study, so without placebo. Blue is having placebo, okay? You can see that for head-to-head study without placebo, the same patients randomized to the same drug have higher probability to respond and lower probability to drop out compared to the same patient in a study with placebo, blue, where they have lower response rates and higher dropout rate. So this is a big problem in the analysis because placebo-controlled trials are clearly inflating the efficacy of some drugs and reducing the effect of others, because this is not consistent across the 21 drugs, because the number of placebo-controlled trials is different for each drug. This is the reason why the league table in the latest Lancet paper in 2018 is without placebo. So from agomelatine to vortioxetine, but there's no placebo. So when we look at the comparative data, one antidepressant versus the other, we excluded placebo. So all this is reported in the paper, but sometimes people read the paper, they skip this step, which is crucial to understand why we ended up with this league table. And after last night, I mean, this is identical to migraine. I mean, we have so many treatments in terms of acute, preventing. So a situation like this league table can clearly be replicated in other fields. I think migraine, I'm working also with people in pain or in surgical procedures, from transplant to cardiovascular and pulmonary surgery. So it's impressive how this methodology, diabetes, HIV, can apply to many, many fields, especially when, like here, you have many competing options for the same problem. Okay, so talking about, Lily, talking about the shape of the network, I'm trying to convince you that the first one was more connected, is this one. This is another paper we published in the Lancet about acute mania. And this is the network. You can see very, very, very different. We have fewer connections, all compared to placebo, but gabapentin, lamotrigine are not connected to aripiprazole, one of the newest, only a couple of head-to-head comparisons. So this is a terrible problem from a methodological point of view, because we cannot test consistency for all the comparisons. So we are on shaking grounds. So what we did was to use this natural meta-analysis to improve the way we report the results to clinicians and to patients, because this kind of, or the league table, are very difficult to digest, especially for patients, or especially for people in busy clinics. So what we did was to report graphically the ranking for efficacy and acceptability for the drugs. So you can see here that the first drug for efficacy in acute mania is haloperidol, then risperidone, olanzapine, quetiapine, aripiprazole, lithium all together, and so on. This one, gabapentin, topiramate, and lamotrigine are, gabapentin and topiramate are worse than placebo, which is quite exceptional. But this is what we found in the natural meta-analysis. In terms of acceptability, you have olanzapine first, risperidone second, quetiapine third, and so on. So haloperidol is very effective, but not very well tolerated. By contrast, olanzapine and risperidone are very good. So this is a way to simplify the results. This is very nice way to report the ranking, very appealing to clinicians and patients, but there's one big flaw in this graph that we did more than 10 years ago. Any idea, Lily? What's the big problem? Compared to what we started from, we want to know how they rank together, but at the same time, how big are the differences? I'm telling you that these two, for instance, haloperidol is better than risperidone, first and second, but how big is the difference between the two? They can be very close together, and there's always a winner, but clinically speaking, if they are very similar, probably the difference is negligible. So what we did, we developed the methodology using this other way to report the graph. This is dropout in the y-axis and mean change score. So, sorry, probably. Okay. Okay, sorry. 5 minutes left. Can I go back to the... Thank you. So this is... this one. Okay, so this is mean changes, which is efficacy. And you can see that actually the difference to risperidone and haloperidol in terms of efficacy is negligible. And this is a cluster diagram. So we use symbols to highlight drugs that are very similar in terms of overall profile. So these two, olanzapine and risperidone, are very similar. Haloperidol is completely different, very effective, but different in terms of dropout rate, worse than the other, and so on. So this cluster diagram is another way to improve the way we present data. What we did very recently is the Vitruvian plots, which again fits very well when we have to compare multiple outcomes. This paper is submitted, so this is the first time I present the Vitruvian plot to an audience. But the concept is to have, in this case, we have acute treatment, long-term treatment, so we have 7 outcomes, and safety, so number of participants with adverse event is across at the study endpoint. And we have for each drug, placebo, benzodiazepine, and so on, what is the percentage of people responding acutely, having dropout acutely, and having dropout with adverse events acutely, responding long-term, having dropouts long-term, dropouts to adverse events long-term, and overall number of people with adverse events. These are patients randomized to placebo. These are the patients randomized to the drug. So the colors represent whether the drug is better than placebo, and the numbers tell you how big are the differences. So here is 19% placebo and 35% response rate for benzos. So it's very good for efficacy. But if you look at the adverse events, 51% people with adverse events for benzos compared to 39 placebo. So it's a way to improve how we, in a synoptic way, we present the results to patients and clinicians. Okay, it is evolving, but I have to say that the real step change will be to make this a dynamic thing. So it's not on paper, it has to be tailored to the patient and also be interactive. So it changes depending on individual patient characteristics. Yeah. So, sorry. Okay. So just to finish, a couple of things. One is the role of natural meta-analysis has to be in terms of comparative effectiveness. We said this morning with Dr. Do about the lack of direct comparisons. This is a series we published a couple of years ago in The Lancet, highlighting the importance of natural meta-analysis after drug approval. It is an unmet need across whole medicine, not only for drugs, but also for devices. But paper 1 of the series was about the before approval. And this is where natural meta-analysis can really help, because if we do a natural meta-analysis now, and like this morning, we identify a gap in the information about the natural meta-analysis, as regulatory agency, we can ask companies to do research in that area. As academics, we can work with companies to fill the gaps and help patients having better outcomes from treatment. So that's an important thing to mention, especially to industry, to convince them that natural meta-analysis is the way forward. So just to finish, can we use natural meta-analysis to personalize treatment? The short answer is yes, I think. Let me show you an example, because we need 2 things. One is we need individual patient data. If we use aggregate data, we have averages of treatment, so we don't really go into the individual patient level information. This is a paper we published a few years ago from a from a natural meta-analysis of individual patient data comparing 3 treatments for chronic depression. And it's interesting because the average effect favored treatment A. But if you look at what happens to the patients, this is completely different. So these are patients recruited in the study where at the end we said A is the best treatment. But look at Helen. So she's clearly a female. She's severely depressed, severely anxious, very young, no family history of depression, and short duration of symptoms. Her trajectory of depressive symptoms over 12 weeks is this. So over 12 weeks is not A, but it is C, the best treatment. And with these prediction models, I can tell Helen, look, you will experience a tiny improvement over the first 3-4 weeks, but then it will be a real improvement. Okay, so you can help also the patient in the journey across the recovery from the symptoms. But if you look at Steve, of course these are fictional names, but this is a real male with less depressive symptoms, same anxiety, slightly older, with family history of depression, a longer duration of symptoms. The trajectory is completely different, and B is the treatment of choice. So this is where individual patient data and network meta-analysis, so we have everything versus everything, we can predict the treatment, and we can tell the patients what is their most likely outcome if they take one medication or the other. The problem with this is that it's not really personalized, it's stratified, because we have not only Helen, but other women who have the same severity, same anxiety, same age, and so on. So in order to personalize, we need data from the biomarkers. We need to know inflammatory index, the genetic is crucial, of course, all these dimensions, imaging, and so on, all these dimensions, plus patient preferences. Because depending on my preference about the adverse events, I can decide to go for one antidepressant or the other. And this is the project we are running now. So we have developed this treatment algorithm to personalize treatment in depression. It's called Petrushka. And we are able to predict what is the best antidepressant for each individual, incorporating their preferences. This is, again, a simplified version. But what we do, to Steve, we ask him, what do you think about nausea, insomnia, sedation, and so on? And this is his rating of the different adverse events. So Steve is not really bothered by insomnia, nausea. He doesn't want sedation. Weight gain, it's a real problem for him. And also we ask the medic, is there any cardiac problem? For instance, QTc, prolongation, whatever. And the medic says, no. Okay, in this case, this is the ranking of the antidepressants, and you can choose the one that best fits your needs. But if we have another patient, same age, same baseline characteristics, but different preferences, because Nick doesn't care about insomnia, but nausea is a problem, and tremor is a big problem because he's doing an admin job, and he has a QTc prolongation, the ranking of the antidepressant is completely different. D, which was a fourth-line treatment, is now probably the first. And we have additional antidepressants that may be used for this specific patient. So this is the protocol and the rationale of the project. We are about to start the trial in the late spring, early summer. And of course, I'll be happy to give you more detail about this and hopefully come back with some good results. Thank you very much.
Thank you very much, Professor Cipriani. It was very interesting and intensive course, I think, on meta-analysis. And now we have some time for questions from the audience, here or online too. And I can see Dr. Do has a question.
Hi, first of all, thank you for an excellent talk. I have a question regarding comparison of old and new trials, which is obviously what we're all interested in the end. Outcomes of the trials have usually changed over time. Maybe it's, in the case of migraine, it's migraine attacks and then migraine days. And a lot of the trials don't include both. How do we make sure that these trials or these outcomes are comparable?
Yeah, this is a problem also for standard or pairwise meta-analysis. And I think there's always a balance between getting the most we can from the data that we have. So there's no golden rule except that deciding a priori what are the criteria to possibly lump and combine some outcomes or keep them separated. what we do is, especially if we have trials having two outcomes, or measuring the same outcome with two different rating scales, we can use this data at the individual patient level to find a correlation, and then we can impute the information from the other studies and plan a sensitivity analysis at the end. So the primary analysis is everything together, and then a sensitivity analysis where we exclude the studies with the imputed outcomes, and we expect that the results are consistent. But there's a way forward, I think.
So we have another question.
Yeah, thank you. Anne Bylowsen and the patient.
If you can open the microphone.
Yes, I hope it's open now.
Probably you need to.
Det gør jeg også. Okay, kan I høre mig nu? You can hear it? No. Den vej, okay. So, thank you very much for an interesting lecture. I hope that your methods and your ideas in this lecture will be applied to the migraine patients, not just here in Denmark, but hopefully all over the world. Because I have the impression that many of the migraineurs get standardized treatments according to the national guidance lines, and no consideration to the actual requirements from the patient. I would also like to take the opportunity to say thank you very much for letting a patient coming into this general cooking of science in migraine. It's interesting to see what goes on in the research group. This is not for you in particular. But what I have noticed is that you are very much limited in general, all your doctors here, in your research into what I see as being preset concepts. There's not a lot of curiosity in the reports we have seen. And from a patient point of view, curiosity is what brings us new things. I would like to say that as a patient, what we want, and I think I speak for all migraineurs in the world here, we want to have a life quality which is acceptable. And acceptable means not too much pain, preferably very little pain. In this country we get imposed with a lot of pain because we have to be detoxed and we have to do all sorts of things where we don't get enough medicine to keep us pain-free. And I hope in the long run, somehow, you researchers and everybody else who is in the say of what happens in the development of treatment of migraine will focus on how we are kept pain-free. For the moment, our doctors send chronic migraineurs out the door saying we can't do any more for you, and we hope you will have a nice life, which they won't. They go out the door and think about suicide. That's what I hear from the patients. So please think of our life quality when you think about treatment, how we can do it better, how we can improve the life for, in this country, we're a small country, maybe 50,000 people who are basically in pain every day. So I hope to see some progress in those directions, seen from the patient's point of view, and I hope you will take it as an attempt to make a positive statement out of a very negative situation. Thank you.
Thank you. I can then let Lily reply, just to say that the same situation is for not just for migraine, but for psychiatry is the same. It's important to have meaningful outcomes for patients. And this is why now we have what we call PPIP, which is patient and public involvement, engagement, and participation. And if you look at the Petrushka protocol, we have a patient representative in the group. And I remember when I showed this, Roger, his name is, when I showed him the the slide with the sliding bars, he said, you're asking me about nausea or about headache or whatever it is, but the big problem is the severity of the symptoms. It's not a generic interpretation of the adverse event. And this is why then we went back and we asked for more data. So this is an example how it's important to work together in this. I don't know really if you want to comment.
No, I think it's very true what you say. And in migraine, I think also there are many advancements in the recent years for new treatments. And of course, we need to keep working towards the goal for better and more effective treatments. And before we get Afrim to ask his question, we have a question from the online audience from Dr. Kwang Po Peng. And he is asking if there's a minimum requirement for network meta-analysis to be valid, and how many head-to-head comparisons are needed when you investigate the efficacy of an example of 6 medications?
So in theory, there's no minimum in the sense that we can use network meta-analysis also in a star-shaped network. So even if we don't have head-to-head comparisons, having trials comparing drug A, B, C, and D with placebo, we can also benefit from the network meta-analysis because we can calculate the indirect evidence. However, we cannot test the consistency because we don't have the closed loop, which means that it's crucial that the transitivity assumption holds, which means the more homogeneous are the study, the population, the intervention, the stronger are the results. But if you ask me, in terms of having a network comparing head-to-head, what is the minimum number of studies, one can be enough. We don't need, so the more the merrier as always, but if we have one study comparing 2 active treatments is enough, the key element that I didn't have time to discuss today, but it's crucial, is the quality of the data. So that's more important than the quantity.
Thank you. And then one last question from the audience.
Yes, hi, my name is Afrim. I have a question regarding, a theoretical question regarding transitivity and heterogeneity in this case. So my understanding was that we set up a lot of criteria about patient characteristics intervention and say, okay, these groups can be lumped together to do a network meta-analysis. But afterwards, after you have gathered data and you calculate on, let's say, the heterogeneity, is there some sort of threshold for how much quantitative heterogeneity is allowed before we proceed with the meta-analysis?
Sorry, are you talking about heterogeneity or
yes.
inconsistency?
Heterogeneity.
So heterogeneity, again, it depends. However, if I have to give you some numbers, so the I-square is one way. There are more sophisticated ways, but if keeping the things simple, I-square means it's a percentage that tells you how much the heterogeneity between the studies is impacting the final outcome. So if it is less than 30%, we are happy. If it is between 30 and 50, it is a bit of a problem. More than 50, it can be so big that you have to, it's not possible to do the meta-analysis. However, the most important message to take home is whatever is the heterogeneity, you need to explore why you have the heterogeneity, because it may be that you find, in the example I showed you before, that people are, the assumption was there's no difference men and women, and there may be a difference, or kids and adults, or studies carried out in the US compared to studies in Asia, and so on. So there may be explanations, and this is why it's important to explore. If you don't find any likely explanation, and the heterogeneity is above 50 or definitely above 75, the final decision may be, sorry, it's not possible to lump the data.
Okay.
But this is true also for pairwise meta-analysis, not just for network.
Yeah, but so you would explore first and see if there is any meaningful yes or no.
Yeah.
Yeah, cool.
And now one final question from the online audience, where Teresa Catarsi is asking, saying that in her opinion, in the first visit, when you see a patient, you use clinical trials to make a treatment choice, but then in the follow-up visits, you might use your personal experience. So what do you think about that?
Well, I think that we should have an evidence-based practice. So it's personal experience, clinical experience is part of the decision-making process. We know that when the paradigm of evidence-based medicine is not just the best research, which is one component. We also have patient preferences, as we said today. We have the clinical state and circumstances, and we have a fourth dimension, which is cross-sectional, which is the clinical experience. However, for all the steps in the decision-making process, we need to look at the available data. And for instance, what we are trying to do with Petrushka, but I know you are also doing this here, is to overcome the dichotomy randomized observational and trying to combine all the high-quality data into one estimate that can help the decision-making process. So I still think it has to be driven by numbers and good science.